me the topic. The topic was back pain in adolescents with a bracket which says bookworms. So I was told that you confine it to the bookworm. So I'll confine it to myself. All of us in our homes have, especially my age group, have either kids or some relatives, and that's mine. Always sitting there crouched up on the book, looking at the books in different forms. So this is something we're going to see more in our practice. And what's the relevance? Adolescence is an age group where you have young people from the age of 10 to 19. The importance lies that they are the future productive workforce in our country and beyond. And they are an impressionable age. They are an age where you can kind of mold them right, which our parents didn't do to us or did to us. A well-executed history in your office practice gives the strongest predictor of a future low back pain. And since it's early onset, it's obviously going to turn chronic. So pick them early. Puberty has varied growth patterns for males and females, but the incidence of back pain actually is almost equal in most epidemiological studies, though the causative factors might be different. Why are we discussing this? I think in 2018 in up north in America, they had a survey done at the school level that 446 children were randomly picked and looked for mechanical low back pain. Mind you, non-pathological mechanical low back pain. And 26%, that means 1 in 4 kids actually had some back pain at some time, and 80% of them were indulging in sporting activities. No gender bias, and most of them was tennis and soccer, and 80% of the gymnasts had some problems. So if we are going to turn a sporting nation, which is what we want to, as you see now, with more and more people getting up medals in different podiums, we have to keep this in mind, and we might see this more often. Most commonest maneuver is the extension of the lower limb. And in last 5 years, epidemiological studies say that the prevalence is far more than what we think it is. So what's the reason? A little philosophical thought. Parents' expectations. I know that our generation wants our children to do everything in a small 24-hour day schedule. So we are parents who want our children to be Einstein, Roger Federer, and Bhimsen Joshi put together. And if you look at them, if you look at a child's schedule today, they go to school, tuition, then a music class, and suddenly they are in the night doing karate. Is that the problem? That they're juggling too many things in a small span of time? And when they do it, then they have peer pressure, because there's the next guy sitting next to you in the school's doing it, so I might as well do it. So peer pressure, which eventually burdens them with competitive edges, and that's where it's probably happening. Or is it because we are overdiagnosing it? The parents are more careful, more, looking at what's happening to the children, and you find many parents there. And as doctors, are we actually looking more? Because you see what you look for, and that's probably the other reason. So let's now go through the standard etiological charts. Let's go different. In 2021, there was a classification or a categorization, if I might call it, of the adolescent back pain to muscular, bone-related, discogenic, and others, with or without pain amplification syndromes. And we'll discuss that later as we go on. So muscle-related is the main commonest reason. I think it happens because there is an extreme shift from a sedentary, sitting, school-oriented to sudden shift to high-intense sporting activities without adequate training. So it could be a heavy rucksack at one stage, prolonged sitting, the true bookworm as we call it, or because you are getting trained for sporting activities without the right equipment, without the right training, which is possibly causing it, over and above the peer pressure and the psychosomatic reasons. The bone-related ones are 18% of the total group, and spondylolysis, probably the past defect, which we all know, which is initially asymptomatic, probably constitutes the maximum. In an adolescent athlete, which is done in over the many series that has come out from the UK and in the Europe, 47% had some form of injury. And the commonest ones will be the ones which has got extension and flexion, repetitive injuries, microfractures, they heal, then again break, what we learned as, elongated pars, all those are probably the commonest causes. 15% of this lysis we know go into listhesis, and that happens maximum in the teenage growth spurt period. And initially it was thought it's because it's chronicity of pain that leads to listhesis, but later it was known it's more because of the lumbosacral kyphosis. AIS, or adolescent idiopathic scoliosis, do not primarily cause back pain, though it's higher incidence in a female, but don't fall for the obvious. Because here you see a pure lumbar, the type 5C scoliosis happening there, but if you actually look at what's happening in both these cases, it's the listhesis which is causing the scoliosis. So you correct the listhesis, the scoliosis autocorrect. So in your office practice, if you see something which is scoliotic, don't forget to look down at the lumbosacral junction. It's an important junction. What about bone-related pain, which is due to a kyphosis or Schumann's? Now, we believe that in India, we don't see too many Schumann's. It's true, because the incidents are less. But what's it causing it? You know that at the bone, the vertebrae develops, there is what we call as a ring apophysis. So there is the vertebrae, the ring apophysis, and the disc. The ring apophysis at some stage is actually even weaker than the disc. And therefore, there is a constant breakdown if there is a constant impact force, which causes what we call as a degenerative wear, especially in the thoracolumbar junction. But when it happens in the lumbar purely, it's called as the adolescent disc dysplasia. You can see there in the mark there, that's actually the cluster's limbus vertebrae, which we see in a lot of adolescents, which is there. Pure disc-related pains, only 8%, and we know it's associated with flexion extension movements or sciatica. But fortunately, even now, the pure disc cause of back pain is actually around 3 to 8%, so it's not too common. But early degeneration, I've seen in some of the kids now, they go with their brothers to the gym. The brother is about 24, hitting the gym, standing out to be Salman Khan. And the young guy at 16 is doing it much earlier. So the question to ask is, are the discs being loaded too aggressively, too early in life, which is causing the degeneration so early? And I can bet all of us see early degenerations much more than what we probably would see earlier. So risk factors is trauma, Schumann's, a family history, not so what we call evidence-based, obesity, childhood or adolescent obesity, and sporting activities. What about the others? The quick run-through of the others, tumor, osteoid osteoma being the commonest, the presentation very clear, night pains, they get up at night, better with analgesics, or infection, which could be actually vertebral osteomyelitis, spondylodiscitis, sacroiliac joint infections, or for that matter, something which is totally non-spinal, something like a pyelonephritis, as you see here, or appendicitis, the retrocecal appendicitis that can present. So don't miss out on these. When we are orthopedic, we look at bone, but there is something beyond the bone. Inflammatory arthritis, though not very common, but is seen early in life in the adolescent phase, either juvenile angstpon or reactive arthritis or psoriatic arthritis. These are generally aching nocturnal pains, and they get up generally in the morning very stiff, and we know how they present. And the systemic illnesses, the fibromyalgias, the blood malignancies, children treated with leukemia because of immunosuppression, metabolic diseases because of pure nutrition, and connective tissue disorders. The important group is this pain amplification syndrome. So because of a very high index peer pressure lifestyle of the children, some of them come with no identifiable cause. And they have multiple sites of pain, back being just one of them. And the classical history is the mother actually tells you the history more. Beta, aap bol nahi paoge, main bolti hu. And then they start. So half the time she's telling you the history and the child's like sulking away and sitting quietly. Be careful, because these are the ones where the parent's more concerned than the kid actually. So pain amplification syndrome, constant asking, aapko to koi problem to nahi hai, kamar darad ho raha hai? And that tends to cause this, very common, and it can actually overlap with the others, so you can get confused or caught. But in practice, and since the theme is office practice, take away 2 take-home messages. One, you look for red flags, and there is a series of them, and we all know them in the textbooks, but I'll run through them quickly. Fever, trauma, unrelenting pain, not getting better for about 3 to 6 weeks or beyond, obviously features of cauda equina, immunosuppression, and with the high index of drug abuse in young children, adolescent, don't forget that also, which is increasing in our country. Yellow flags, look at the way they behave, how they behave sick. They feel that they have no hope. Most of them don't even look at your eyes. They are very comfortable looking at the screen. So I feel instead of bookworms, you should be talking about screen worms, because they are more in the screen now than otherwise. But these are yellow flags you should not forget in your office practice. So how do you approach this in your office practice? I think this is an algorithm, busy slide, but I thought I'll cut it into 2 halves. So when you have a kid come into your, or rather adolescent come to your clinic, have a thorough history, a physical examination, and even including everything, right from kind of nutrition to the exercises they indulge in. If you have no red flags, then you don't bother. Go ahead and look at screening. If you even need, take a counselor's help, especially if you find the yellow flags. If there are none of them, you can label it as a non-specific low back pain. And obviously then go through the treatment for the next 4 to 6 with rest, adequate rest, not complete rest, but adequate rest, analgesics, rehab, exercise, and counseling. Whereas if you find there is something wrong in the red flags, investigate and find the cause. When you find the cause, I don't know how clear this is. I'm sorry if it's not too clear. It's clear? Okay. So if you find the cause, then you look for the causes that we discussed, the lysis, the listhesis, the malalignments, the sacroiliac, or a disc. And if you know the cause, go by the conservative line. There's no question that 87% of these patients can be treated conservatively. That's a big group, mind you. If it fails, look for more other off-the-beat conventional treatments and then follow up them more. The big problem is you treat them as a dynamic or a static entity, but do not follow up. So keep following up. It's a very few group, as I said, who need surgical intervention. So remember, back pain in teenagers is not uncommon. Characterizing the pain and identifying the red flags are vital because you want to not miss on potentially serious conditions. A proper history, inquiring about the life at home, activities of daily living, and recreations may unearth the precipitating factors. The psychosomatic component can't be overlooked. Most of them are mechanical and they need just proper rehab, nutrition, and counseling. And some with definitive pathologies need to be treated at